going to talk today about the shoulder pain. It is of course very important topic, and especially for elderly population. So what is the causes of shoulder pain? There is in fact many causes, but the most common cause in the vast majority of patients would be the arthritis. So in arthritis, the patient usually have a pain around the shoulder joint, and this is always the first differential diagnosis when we have patient presenting with shoulder pain problems. Of course, we need to look at the age of the patient as well, because arthritis is more common in elderly population compared to the young people. If the someone who is young and present with shoulder pain problems, it could be the case that he had inappropriate exercise, or he has trauma, or he had an excessive movement that caused a rotator cuff tear. So initially, when I see any patient with shoulder pain in the clinic, I do need to do a full examination, and of course to take a detailed history as well. From examination, I can find out what is the exact reason of shoulder pain. So what is the differential diagnosis of someone who is presenting with shoulder pain problem? The most common would be the arthritis, as I mentioned. Also, we need to think about the rotator cuff injury and rotator cuff impingement. So I do always ask if there is any history of trauma, or if the patient play tennis or golf, or any kind of exercise in detail, to find out if he had any relation, if he had any exercise in relation to these pain problems. After that, I do speak about the examination, and in fact in examination I do need to find out. So if the patient has a shoulder pain problem, detailed history, then examination should be followed. For examination, there is a possibility of having rotator cuff impingement. Also, bursitis is a very common problem, and in bursitis there will be different types of bursitis. So it could be subacromial one, subdeltoid bursitis. These are the most common. Also, there is bicipital tendonitis, which happen quite often. Usually old age is of course different from the young age population, so I always advise to the patient to get initially an x-ray for the shoulder to see if there is any form of arthritis, and if I do need to refer him to an orthopedic surgeon or not. Usually orthopedic will intervene if there is severe arthritis and if there is a need for shoulder replacement surgery. However, in many occasions, the orthopedic team can do arthroscopy, which is just to do a washout and to have a look inside the joint. Also, sometimes the orthopedic interventions include rotator cuff repair. I would say some of the patients get benefit from the rotator cuff repair, but some of them, unfortunately, they still have pain problems after the surgery, and the more they go for surgery, the more they will be prone to have more chronic pain problems in the future. So I would really advise anyone who is planning to repeat shoulder surgery to consider really asking the pain consultant, and to find some other options which would be conservative rather than invasive techniques. So if the patient has then keyhole surgery and he's still in pain problem, usually they come to the pain clinic after everything. So it is the last step in the treatment, and here is a difficult situation that we will be in, because the patient always will suspect to have treatment, and in fact he has tried everything else but nothing did work, unfortunately. And here we need to be very honest and very clear with the patient to tell them what is the diagnosis and what is the percentage of improvement And always we need to put the fact that the injections is a diagnostic one. It could help, but in the other hand, if it doesn't help, it means that we need to find other solution for the chronic pain problems. So if the patient has rotator cuff injury or bursitis, the treatment will be completely different. If the bursitis is a problem, usually I send the patient to do ultrasound of the shoulder or MRI scan for the shoulder, and it will show exactly what is the type of the bursitis involved. When I have these results, I can actually then take them to theater, and under ultrasound guidance, I can aspirate the bursitis fluid. I have a very good recall of one of my patients who was 93 years old, and she had severe shoulder pain problems on both sides, which did not respond to any treatment, including morphine patches. And for this lady, actually, um, I was delighted to find out that she had a subacromial bursitis. I did actually withdraw around 20 mils of serous fluid from her bursitis under ultrasound. Then I have injected a steroid with a local anesthetic. You cannot imagine how much relief she got. She was like in agony before the procedure, and immediately when the bursitis was aspirated and injected, she felt immediately the benefit of it. She was so happy that she is able again to go to her garden, small garden, and enjoy her flowers and the social life outside the house. So the results can be quite amazing if it's done in a correct fashion. If there is no bursitis, then we are left then with arthritis of the joint, and for this problem we can do a steroid injection under ultrasound guidance. Also, the alternative will be a plasma-rich platelet and the hyaluronic acid injection, which give an excellent result as well in my view. If the patient has rotator cuff impingement or the arthritis that did not actually improve after having these steroid injections, the alternative, what is the alternative? It will be actually suprascapular nerve block, and it is initially a diagnostic block where you can use an ultrasound guidance. Initially I was using nerve stimulator, but there is no need now to use this anymore when you have enough experience to do this type of injection. With ultrasound you do the diagnostic injection, and they suggest to do it with the local anesthetic only with no steroids, but in my experience I do both because I feel that steroid might prolong the effect of the block. If the injection was successful, then pulsed radiofrequency treatment can be offered, and this is really good because in this treatment you offer the patient prolonged benefit. Of course, we cannot do radiofrequency ablation because the suprascapular nerve is coming from C5 and 6. It has some motor branches to the infraspinatus muscle. So we cannot apply any radiofrequency ablation here. So I will advise to do only pulsed radiofrequency treatment. As you know, the suprascapular nerve supplies 70% only of the shoulder joint, and there is 30% that come from the axillary branch. So I don't go straight to the axillary block. I usually do the suprascapular block first. If the block was not completely successful, then I inform the patient that I can offer him combined suprascapular plus axillary branch block. And of course, it is a diagnostic one again. After the block, we will make another assessment, and if the injection doesn't work, then we don't offer injections anymore. But there is so many other ways to help, and this include morphine patches as a last resort. So I hope you find this video to be useful, and I hope to see you again. If you have any question, please contact me through my website www.paintreatment.ie. Also, subscribe to my channel, please, and you can put any question in the comment. If you want to interact with me in the forum, you can find me on my Facebook page, which is Chronic Pain Consultant Galway, because I run my clinics in Galway Clinic. I hope to see you again, and best of luck. Thank you. Bye bye.